Good evening, everybody. Today is Thursday, October 6, 2022. We're doing a caseless defense for the next hour and a half. We're going to go till 10 o'clock. Just with a show of hands, can you hear me? Is my audio working? Okay, thank you so much. You can lower those hands. Anybody have any questions before we start? You could always put them in the question box. You can raise your hand before we start. I see somebody with their hand up. Give me a second. I'm going in that direction. Kendra, it says you're self-muted. Are you there,
Hello.
Kendra?
Yeah, sorry, my hand was still up, letting you know that I heard you.
Okay, do you want to be part of the hot seat?
Sure.
You don't sound too excited.
I mean, are you ever excited to do these things? No, but
Not really. All right, you want to do something from your case list
Yeah.
or just a topic? What are you looking for? I know I turned off my screen. I'm here trying to.
Okay. Something from my case list is fine.
Okay, let's find your case list. Any specific section?
No.
No specific section?
No specific section.
No. Okay, all right. I'm just looking at your list, okay?
Mm-hmm.
Case 22. In your office.
Yes.
Okay, present this case for me.
So this is a 22-year-old G1, now P1 female who presented approximately, I'll just say several weeks postpartum with complaint of breast pain, chills, generalized body aches.
22.
Sorry?
22. Case 22.
Oh, sorry.
Number?
Sorry. Sorry. I saw 22 on the page. Okay. I was going to take case 24. 22. So this was a 28-year-old G0, P0 female who presented for her annual exam, and she had also complained of tender labial bumps. At the time of evaluation, I did a history and physical exam and found that she had firm flesh-colored perineal lesions, which I did biopsy in addition to performing her cervical cancer screening.
Why did you biopsy the lesions or one of the lesions?
Because at that time I was not 100% clear on the diagnosis, and I did not want to mistreat her lesions.
So what was part of your differential?
Part of my differential diagnosis included, since they were tender but flesh-colored perineal lesions, a molluscum contagiosum, skin tags, not Haemophilus ducreyi. I was able to biopsy it, so I wouldn't necessarily say it was a herpetic lesion, but those two were at the top of my differential diagnosis.
So what causes molluscum?
That is caused by a form of the human papillomavirus.
Sure about that?
No, I am not.
And what treatments are for the treatment of genital warts?
Treatment of genital warts includes solutions that can be patient administered, in addition to provider administered, trending towards surgical intervention with excision, including laser therapy.
So what medications are available?
Trichloroacetic acid is available, podophyllitoxin, imiquimod as well.
Any other medications?
These are the ones that are coming to the top of my mind. I cannot recall any others at this time.
So the imiquimod, what's its mechanism of action?
I would be lying to say that I know the mechanism of action.
Now, do you use that in your practice, the Aldara?
I personally have not used this medication since being in private practice.
You used it as a resident?
Sparingly. I can certainly count on one hand, maybe even one finger, the number of times I've used it.
Okay. And in regards to, you said surgical treatment, what surgical treatments are there? You said excision, laser, anything else?
I believe cryotherapy may also be a treatment option.
So how did you treat patient 22?
This patient, I administered podophyllitoxin.
And how did you administer it? Can you go through your
This,
protocol?
this medication is placed on the lesion, I believe, every other day for several weeks.
You believe, or you did that?
I believe I did that. I cannot recall.
I mean, is this something you do routinely in your practice, or you have it on your list?
I do have it on my list. I do not do it often.
So what type of follow-up did you instruct the patient?
She was actually lost to follow-up.
But she had 4 visits.
The first visit was for her annual exam. The second visit was for the biopsy. The third visit was for her colposcopy, and the fourth visit was to go over results.
So she had an abnormal pap smear. She has condylomas. Was there any discussion in regards to Gardasil?
I believe there was discussion of this, and she had received the vaccination series.
So what are contraindications to the vaccine?
Allergy to its components.
Anything else?
Not that I can recall.
So everybody can take this vaccine. other than having an allergy to the vaccine?
No, there is an age restriction on its use.
Anything else?
Possible immunocompromisation.
Anything else?
Not that I can recall.
Can you tell me what subtypes are covered by the current vaccine?
Strains 6, 11, 18, 16, 31, 33, 45, 52, 58. I'm not sure of 58.
Let me go back to the condyloma. If the patient was pregnant, what treatment options are available?
A pregnant patient can undergo cryotherapy.
Anything else?
There is a topical solution that can be administered. I believe it is imiquimod.
Okay, let's stop there. What do you think?
Horrible.
Something so simple can become so hard. I mean,
Very.
realistically, you should know how to apply the agent because you do have it on your list. Okay.
Yeah. Yeah.
So I would have flubbed it. I would have said, oh, I would have brought her back, and I mean, you may have been wrong, but I don't think you would have been way too off, right? Because you've done it in the past, right? Didn't look good that you're like, well, I really haven't done it much, or you know. At that point, I think you just have to admit, yeah, for sure. Again, you should, if you have no idea what they're talking about, then don't make it up, but you do have this on your list, so you have done it before, correct?
Right. Yes.
You were correct with the subtypes. It's 6, 11, 16, 18, 31, 33, 45, 52, 58. So 9 is a 9-valent vaccine. Contraindications, pregnancy. In any vaccine, Guillain-Barré, you can never go
Sure.
wrong by saying Guillain-Barré syndrome.
Pregnancy.
And believe it or not, yeast allergy, because it is based on yeast, how they make it. Treatment options available for the condyloma, Padafidil, TCA, fluorouracil, Aldara, synectitins, cryotherapy, laser ablation, electrocautery, ultrasonic excision aspiration. Treatment options available in pregnancy according to up-to-date TCA, and cryotherapy. Aldara is a immune response regulator. It affects the toll-like interleukin-7, if I'm not mistaken. Should not use it in pregnancy. I don't think there's enough studies as of now. Musculosum is a pox virus. Did I include everything? Did I miss anything?
Mm-mm.
No, but good job. You have never been on the hot seat, right?
I have.
Oh, you have? Last
Not
month?
with you. But I have. Yeah.
Not with
last
me? Does that mean something?
month.
Say I was tougher than others?
No, not necessarily. It's all
I just got a
badness.
topic that you weren't too strong on.
Yeah.
But you do have it on your list.
It's fair game, I know.
I would review, the agent that you used and all that good stuff.
Thank you.
Okay. Other questions? Okay. Good job. Just some tweaking. All right. Anybody else want to be part of the hot seat? Priyanka. Am I saying your name wrong?
Hi,
Are we
yes.
there? Ooh, there's a lot of feedback.
Sorry.
Are you there?
Hi, can you hear me?
Yes, can you hear me?
I'm having trouble hearing you clearly. I can hear you.
Can you hear me?
No, it's not better. I'm not sure what's going on. Do you mind calling on me next and I can try to fix the audio on my computer? I'm not sure
will
what's
do.
going on.
Will do. So you're looking for another hand up here. I'm going to Hattie. Hopefully I'm saying your name right.
Yeah,
You
you
there,
are.
Hattie?
Yep,
Are you a subspecialist or a
I am.
generalist?
REI.
Ooh, what would you like to do then? OB?
Whatever you want. Yep.
No, I mean, as an REI.
Yeah, we don't do OB much. Yeah.
Yeah. Okay, so let's look for your list.
Can I ask you a question before we start?
If I know the answer, my friend.
Okay. I was talking to a faculty member today, and she told me a good strategy during board exam. If you don't know the answer, just immediately say you don't know. Don't try to waste time, because it's not about, like, they count points whether you know more and more questions rather than deducting points about questions that you don't know. So it's rather than just don't waste time, just say you don't know so that you can go on to the next question to get more points. Is that a good strategy? Is that how it works?
We really don't know how they score it.
Okay.
That being said,
Yeah.
in the end, you probably know something about everything. You may not know
Right.
it very well, but you know something about everything. So I don't see anything wrong with doing the caveat of saying, I'm not 100% sure. However, I recall reading something about this. I'd have to double check and get back to you to see, if you were correct or whatever. And at least you can get some partial credit. It's kind of like with the SAT. When I
Okay.
took the SAT many, many, many moons before you guys did, you got penalized for guessing.
Mm-hmm.
So the statement was you should not guess, because if you get it wrong, you get points deducted. However, if you can, you have 5 choices. If you can decrease it to 2, shouldn't you roll the dice and go for it? Because if you leave it blank, you got 0. You know what I'm saying?
Right. Right.
There's also that test taking strategy, kind of like, can you tell me the stages of endometrial cancer?
Right.
First thing, if you don't know all of them, you're going to say, I don't know. Well, you do know something.
Right.
So that's where your test taking strategy comes into play. You'll say, at this time, I can't recall all 4 stages. However, I do know that stage 1 is confined to the uterus and stage 4 is distant metastasis. I'd have to look up stage 2 and 3 and get back to you. You're gonna get partial credit instead of 0.
That's a good strategy. Okay, perfect. Thanks.
You know what I'm saying?
Yeah.
Okay. Is there any particular case that worries you, or pick whatever?
Whatever.
Okay. I'm just looking.
I'm sure you'll find a way to make it worry me.
Case 11.
Okay.
What is fetal growth restriction?
So fetal growth restriction is defined as on ultrasound when we find that the fetal weight is or the estimated fetal weight is below the 10th percentile, or the abdominal circumference is less than the 10th percentile.
And which type of IUGR has a worse prognosis?
If we're talking about Dopplers, we're talking about reverse Dopplers. That would be the worst IUGR,
So let me
and
ask you
less
this.
less than 3%. Are you talking about symmetric versus asymmetric?
Correct.
Asymmetric.
Asymmetric. Why is that?
Because in that IUGR, usually the physiology would be that there's head sparing, so that's why it's a bad prognosis. With symmetric IUGR, it might be constitutional.
Be constitutional. What's a bishop score?
So a bishop score is a way of measuring the cervical way to measure the cervix and how I'm not choosing my words right, but it's constituted of 5 criteria.
So what does it tell you? What score are you looking for?
It tells you if a cervix is ready for induction of labor.
So what score are you looking
for
for?
a score. So anything above 8 is favorable. 8 and above
So let's
is
say you have a score of 10. What does that tell you?
favorable cervix. That means that most likely this is a cervix that is equal to a patient who is in labor.
And do you recall this patient's bishop score?
This patient's bishop score, I remember, was I believe it was 0.
So how was the patient induced and why? What process did you do, or what medications?
Yes, so we started out the induction of this patient with Cervidil, and then once we took the Cervidil out, she was around 1 to 2 centimeters. We placed a balloon.
So let me interject here. Let me
Yes.
interject here. Why did you use Cervidil?
So Cervidil, at that time, we used it. So it's a good option when we have a closed cervix. In my institution, we prefer Cervidil in case the baby does not do well on monitoring. It's easy to take the Cervidil out. With Cytotec, for example, which is also used with a bishop score of 0, it's you can't take the it can cause contractions, and it might cause fetal intolerance, but you can't take the Cytotec out. The Cervidil, you can take it out easily.
So let's say you had fetal intolerance with the Cytotec. What would you do?
Well, first you'll have to start with resuscitation. I usually go in, like I usually might, with gloves, try to remove any Cytotec that's there if I'm thinking that that's being caused by contractions that I'm seeing on the monitor because of Cytotec, because she would not be contracting otherwise. I would try to remove any Cytotec that's still there next to the cervix or inside the cervix. Otherwise, I would start fetal resuscitation, which means flipping her on her side and seeing if she needs any, if her saturation is lower, I would give her oxygen, give her a fluid bolus, and doing all of that.
So let's say she doesn't respond to the intrauterine resuscitation. What would you do?
So we're talking about like what kind of tracing? Like a category 2?
So you have a category 2, yes.
Okay, and it's not responding to any. Basically, if my resuscitation is not working and we're still having a category 2, I mean,
So let me put it this way. Let's say you have tachysystole.
Okay.
That's why you have your category 2 tracing. What would you do?
So in that case, I'm blanking on the medication. We would give. I'm blanking on the medication that you give. There's a medication that you give to stop the contractions. See, this is what 1.5 years away from Strep6 does. It's a medication that you give when there's tachysystole to stop contractions.
Can you tell me the dosing, route of administration?
I do not remember.
Let me go back a second. You had said with your fetal growth restriction, something about reversal of flow.
Yes.
So when are umbilical artery Dopplers abnormal?
So umbilical arteries are abnormal when the SD ratio is, I believe, abnormal, higher than 99%, I think.
90% of what?
Higher than the 99th percentile.
Any other indication where they would be abnormal?
So there's reverse, there's absent, and there's decreased flow.
And did this fetus have any of that?
No, this fetus had normal Dopplers, and it was in the 3rd percentile.
So why was the decision made to deliver at 37 weeks?
When they are at the 3rd percentile, usually the indication is to be done at 37 weeks.
So how to diagnose endometritis?
Endometritis, in this case, she had a high temperature of, it was 102.7 afterwards, a few hours afterwards. And
What do you mean by a few hours afterwards? What does that mean?
few hours after delivery.
A few hours after delivery, how many?
It was like around 6 hours after delivery, she had a high temperature.
So was it endometritis or was it chorioamnionitis?
She did not have any signs of chorioamnionitis before that, before delivery.
How did you treat the endometritis?
With Ampagent and Clinda for 24 hours.
Oh, and the ampicillin treats what?
The ampicillin gram negatives.
The gentamicin?
I believe it does gram negative and anaerobes.
And the Clinda?
Gram positives and anaerobes.
And you sure it wasn't chorio?
Based on the clinical scenario that she had a high temperature after delivery, 6 hours after delivery, the diagnosis would be endometritis.
What if I told you you're wrong? What would you tell me?
You might be right.
Let's stop there.
Yeah. Okay.
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 So endometritis occurs 24 hours after delivery.
So after 24 hours.
You picked the right antibiotics, but for the wrong reason. Because the vaginal flora actually changes after 24 hours, to my understanding, after delivery. So within 24 hours of delivery, it is chorioamnionitis. So you treat with ampicillin and gentamicin. Ampicillin usually for your gram positives, gentamicins for your gram negatives.
Okay.
Then the vaginal flora changes after 24 hours, and it's Gent and Clinda. Gent for the gram negatives, Clinda for the anaerobes. If you don't respond within 24 hours after the start of antibiotics, then you add the ampicillin for gram positives. I personally start triples from the get-go, but that's what the book says, for lack of a better word. You're thinking about terbutaline.
Terbutaline, yes, Terbher. My chief
So what's the
Terbher.
dose?
Yeah.
Terbher, that's right. What's the dose?
Yeah.
Route of administration.
It's IM and
Sub-Q.
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 And I'm
0.2, if I'm not
I'm
mistaken,
thinking
0.2.
I'm thinking 0.2.
Yeah, 0.2.
As Methergin, okay. Yeah.
0.2 sub-Q, milligrams sub-Q. You could do every 20 minutes.
Yeah.
Not to exceed 3 doses.
Okay.
But that's a black box warning. You got to be careful.
Right.
Fetal growth restriction less than 10th percentile, or abdominal circumference less than, for the estimated fetal weight, less than 10 percentile of the abdominal circumference. So which has the IUGR that has the worst prognosis? Actually the symmetrical. The symmetrical occurs earlier in the pregnancy. It's either associated with chromosomal anomalies or torch infection. The asymmetrical, it is head sparing. So the blood is usually from placental insufficiency. It shunts the blood to the vital organs, which is the brain and the heart.
Okay.
Umbilical artery Dopplers are abnormal if the SD ratio is greater than 95th percentile for the estimated gestational age.
95th. Okay.
Yep. Or reversal flow absent flow, but you start knowing there's something wrong with an elevation greater than 95 percentile for the estimated statal age.
Okay.
Bishop score, a score of greater than 8 tells you you have the same chance of delivering vaginally as if the patient presented in labor.
Mhm.
Okay. What's in Cervidil?
Cervidil is PGE 2.
And what's the name of it?
So prostaglandin.
It is. How about dinoprostone?
That's Cervidil.
That's right.
Okay.
And we could have asked you about third degree laceration, types of lacerations, those type of things. You had a lot of stuff on this.
Okay.
So questions?
No, that's good. Thank you. I think
No.
Priyanka texted me, said, don't forget about her.
All right. Everybody knows each other. Very nice.
Yeah, yeah. We did the residency together.
We
Yeah.
will. Yeah. Where'd you do your residency?
Yeah, Eastern Virginia Medical School.
Cool. All right.
Yeah.
So hopefully her phone is working. So good
Yeah.
job,
All right.
Patty.
Thanks,
Okay.
doctor.
Awesome. Okay, I am going to Priyanka here. Give me a second. Are you there?
Yes, can you hear me?
Sounds perfect.
All right, sorry about that earlier.
No
Not sure
worries. I sounded like a little chipmunk.
what Yes, on my end you
I could
sounded like a
hear,
robot.
I could hear it in the background, or a robot. Yeah. Are you looking for a specific case?
Not a specific case. This is actually my first time on the hot seat, but any GYN case would be great. I am a MFM fellow, so
Well, there
GYN
you
frightens
go.
me.
Okay.
I much would prefer the line of questioning Dr. Ramadan just got.
Yeah. Did I say anything out of turn?
The only thing when I thought that my TERB's dose was 0.25. I mean, I don't know how nitpicky they will be, but that was the only
Is
thing.
it? I thought it was 0.2.
0.2 for Methergin, 0.25 milligrams for TERB.
0.25. I thought it was 0.2. I would have to check.
I
That's
double checked
Hemabate.
online before I sent it to you.
That's Hemabate.
Yes, 25
Hemabate has the same
micrograms
amount, right? What's the
yeah.
frequency?
Of Hemabate is 15 minutes with a max doses of 8.
No. For TERB.
Oh, TERB, you were right. Every 20 minutes, max 3.
Yeah, but you got to be careful because the black box warning on that.
Yeah, I mean, I don't think I will. I rarely ever give it, much less more than once.
It's funny, when I was a resident, we used to give
TERB like it was candy.
we get it orally. We had pumps, TERB pumps.
hmm
Home health would do for the patient. Yeah.
That's insane. Yeah.
Yep. All right, and you're looking at your case number 9.
Okay.
Of
These are
course.
the ones
Can
I'm
you
the
tell me
most
this?
worried about.
Yep. Can you tell me the stages of pelvic organ prolapse?
Yes. So whenever we talk about pelvic organ prolapse, excuse me, there's 2 different ways you can kind of work it up. I know that the POP-Q is going to be the most reproducible and the one that is preferred. However, the one that I'm more familiar with are the 5 stages, and I'm currently completely blanking on the name of the staging system. But you have stage 1, 2, 3, 4, and 5. Stage 1 is going to be prolapse that is more than 2. How do I describe this? Sorry. I think the best way for me to describe it is kind of starting from, so stage 1 is going to be prolapse that's going to be less than 2 centimeters behind the hymenal ring. Stage 2 will be within, I might be butchering this. Stage 2 is within 1 centimeter on either side of the hymenal ring, meaning in the vagina versus protruding out. Stage 3 is going to be the total vaginal length minus 2 centimeters. And then stage 4 is greater than the total vaginal length minus 2 centimeters protruding out. I think I'm missing one.
Which one are you missing?
I'm not sure.
So can you discuss for me how you counseled the patient in regards to her treatment options?
Yes. So this patient was a 25-year-old G2P2 that had presented after having 2 vaginal deliveries. Both of her children were LGA. So she had significant risk factors for having prolapse. And some of the things that we initially talked about were, I believe, we had talked about her being able to have like a pessary for the cystocele that wouldn't significantly help her with her rectocele. And given that, she decided that she would rather have surgery. She was done having children, and she had had a tubal. So at this point, she said she wanted to go ahead and do surgery. We had also talked about physical therapy, but she had declined given that she said she was done with childbearing and the cystocele was causing her to have urinary retention, and sometimes she would have to stent with the rectocele, meaning
So
that she
let's
would
say
have
the
to put go ahead.
No, you go ahead.
Oh, I was just saying, like, I was just describing the stenting is where she would have to put 2 fingers into the vagina for her to have a bowel movement effectively.
So let's say the patient was 80 years old. How would your counseling change in
If she
regards to
was 80,
management options?
absolutely. So if she was 80, I think we would have a different type of conversation. One of the things that would be important to talk to her about would be one actually would be her medical history, seeing if she's a good surgical candidate, and if surgery was absolutely the thing she wanted, she still declined, doing physical therapy or a pessary. We could also talk to her about a colpoclaesis. Yes, and one of the biggest things with that, however, would be that if the patient is still sexually active, we would not be able to do that. So it would really depend on, one, is she a good surgical candidate? If she's not a good surgical candidate for a longer surgery, we might consider doing a colpoclaesis, which is where you just close up the vagina, essentially, the introitus. But once again, she would have to say that she is okay, no longer, like, not having intercourse. If she still has a uterus in place while doing the colpoclaesis, we would need to make sure that we do a procedure, which I cannot recall the name, where you leave some opening so that you would be able to identify vaginal bleeding if she were to develop uterine cancer or have postmenopausal bleeding after the procedure.
Can you go through for me how you do an anterior repair?
I can try to the best of my ability. So to do an anterior repair, first you would go ahead and place a full, after you obviously do the normal prep and stuff, you would place a Foley so you can identify kind of where the bladder is. And you would need to find kind of the anterior interface where your bladder mucosa and your vaginal mucosa meet, and you would dissect distally to that because you obviously don't want to enter the bladder mucosa. And you would make a little incision until you can find a plane where you have your vesicovaginal fascia, essentially. Once you find that fascia, you would want to lift up the bladder and essentially dissect out a part of the extravaginal tissue, and then close the repair.
So how do you close a repair?
You would close the repair with, I'm trying to remember the words. You would close the repair in 2 different layers. The first layer would be more proximal, and then afterwards you go above it and kind of close the vaginal mucosa, but I couldn't tell you more than that.
But what would you close before the vaginal mucosa?
the vesicovaginal area.
What do you mean by
I'm not
area?
sure. Is it, I mean, you would kind of need to reclose the fascia, right? Like, so you have like the vesicovaginal space that you've kind of created where you took out some of the extravaginal tissue. So I'm not sure what you would call that specific location.
So what is a cystocele?
A cystocele is when the support for the bladder is no longer as strong in the perineum, so the bladder actually protrudes outwards and prolapses into the vagina and sometimes further out into the towards the introitus.
And why does it prolapse out?
Due to lack of support from the vaginal mucosa and the ligaments.
We keep saying vaginal mucosa,
I'm not sure.
but you said it before, and now you're backtracking it.
Well, because you have like your vaginal wall, which, you know, you've got your rectum on one side and your bladder on the other. So if,
I'm telling you about your anterior repair. We're not talking about posterior repair.
right, I'm not sure.
You're chickening out. You said some of the terms. What would you suture together? So you have a weakening of tissue, specifically what tissue? You said it.
Your vaginal mucosa and
Something that's stronger than a vaginal mucosa.
the fascia.
Exactly. So what is an anterior, what's a cystocele in essence?
The bladder protruding out.
Yeah, what is that? It's a hernia of your vagina,
Right.
right?
Right.
We just don't think of it like that, but that's what it is, right? So the
Oh,
fascial
so then you need to
tissue,
reclose the fascia just like you would for like,
exactly,
okay.
exactly. So that's
So
why they started doing the mesh
okay.
years ago, thinking, well, that's what you do with, when you have a fascial defect in the abdomen, it should work with, I'm not a urogynecologist, but it should work vaginally. And unfortunately, it was such a big amount of mesh being used that it was causing erosion. So then that's why the FDA came forward and said, well, you can't really be doing that anymore.
Right. Okay. That makes sense.
Right?
Yes. So you would do 2 layers where first you would need to close but would it be the vaginal? Like, so the
Vesicovaginal fascia,
vesicovaginal fascia.
or the pubal vesicular fascia,
Okay.
followed by your vaginal mucosa.
Okay.
Right? But that vaginal mucosa doesn't do anything. It's not going to give you the support you need, but the fascia is the
Right,
one
because
that
that's
does.
the stuff that we took the extra bit out and then we're closing that back up over the fascia. Okay.
So the important thing is the fascia.
Okay.
You
Thank
recall
you.
when you start to separate the tissue from the underside of the vaginal mucosa, and you use your finger, or you score it, and you start breaking that down, and you bring it in all the way back to where the bladder's at. You have to push that bladder in, and that's when you start, doing interrupteds.
Mm-hmm.
Does that sound familiar?
It does.
I'm going to read it to you here in a second. But you were wrong. It's with your staging. So let me clarify that. It's the Baden-Walker.
Yes.
Stage 0 has no prolapse. Stage 1, the most distal prolapse is more than 1 centimeter above the hymen. Stage 2 is between 1 centimeter above and 1 centimeter below the hymen. Stage 3, the most distal prolapse more than 1 centimeter below the hymen. Stage 4 is complete proscendentia. You brought up the POPQ. They may ask you to differentiate and discuss it specifically. So what I would do is I would just draw that little grid.
Okay.
The little points AA, BA, C, cervix or cuff, and draw that, and there's my POPQ. Because in essence, it's the same stages.
Are
right?
you able to draw that for them?
I'm assuming yes. From my understanding, I did not take the exam virtually. I took it in person. So we had a pad and paper with a pencil in front of us. To my understanding, on the virtual, they do want to see your hands.
Okay.
So I'm assuming they'll be able to see that.
Okay.
Okay. So how do you surgically do an anterior repair or cystocele repair? An Alice clamp is placed 1 centimeter proximal to the urethra along the midline of the anterior vagina, and 2 more Alice clamps on either side of the vaginal cuff or just distal to the cervix, depending if you have the cervix there or not. And I'm assuming she had her cervix still, right?
Yes.
The anterior vaginal wall may be injected with saline or a solution of diluted vasopressin if desired to assist in identifying planes of dissection. A transverse incision is made between the 2 Alice clamps on the vaginal cuff or cervix. Metzabom scissors are then used to dissect the vaginal mucosa off the underlying tissues anteriorly. Once adequate mobility of the vaginal mucosa is achieved, a small vertical incision is made with Metzabom scissors in the midline, perpendicular to the initial incision. The scissors are then carefully placed between the most superficial layer possible in the anterior vaginal wall mucosa and advance with gentle pressure for 2 to 3 centimeters. The scissors are spread slightly as they are withdrawn, thereby assisting in dissection of the vaginal mucosa from the underlying tissue. The path of the scissors is incised, extending the vertical incision. The process is repeated until the level of the Alice clamp proximal to the urethra is reached. Additional Alice clamps are placed on the mucosal edges to assist in retraction. The pubovesical cervical fascia is separated from the vaginal mucosa. The surgical assistants maintain tension on the wide Alice clamps to form an opening like a Chinese fan. Remember that?
Yes.
Okay. Scalpel, scissors, or blunt dissection can be used to remove the fascia from the vaginal mucosa. It is helpful to start the dissection with the scalpel, cutting the pubovesical cervical fascia at the edge of the vaginal mucosa and dissecting it downward with the finger or the handle of the scalpel. This dissection should be continued until the bladder is separated from the vaginal mucosa. The anterior repair is started by placing 0 synthetic absorbable sutures in the pubovesical cervical fascia in a figure-of-8 fashion, starting 1 centimeter below the urethral meatus. The suture should be placed only in the pubovesicular cervical fascia, not in the bladder wall. Multiple layers of closure may be used for larger defects. Care should be taken to avoid excessive tissue plication around the urethra to avoid obstruction. The plication of the pubovesical cervical fascia should continue until the entire cystocele has been reduced. The edges of the vaginal mucosa are held on tension. The excessive vaginal mucosa is trimmed away, and the vaginal mucosa is sutured in the midline with interrupted 0 synthetic absorbable suture. In a nutshell.
Thank you. I have a question.
Questions? Hopefully I know the
For
answer.
prior to surgery, given that she was 25, I don't think we, to be honest, did too much other stuff. She was done having children. She wanted the surgery to be done. What else would you say anything beyond like a pessary and physical therapy?
There's nothing
That-
else other than what you were thinking about, the Lafort, which won't help a 25-year-old,
Right.
right? I'm assuming she's going to continue to maintain sexual activity, so that would not be an option for her.
Right.
the
But for the
thing is
80-year-old, you would do a colpoclysis with the Lafort.
if she's not sexually active.
Right. Okay.
Yes. The thing is, it also dependent on her job. Let's say she was like a weightlifter, power lifter. She lifted boxes. So you're doing a lot of Valsalva maneuvers. She probably is going to have a recurrence.
Okay. So maybe
Especially
more
at
about
such
like
a young age. Say again? I'm sorry.
So I should talk a little bit more also about like lifestyle modifications and things like that and make sure I know what she does.
After the surgery is done.
Okay.
I mean, there's never a quick fix on things. It's in essence a hernia, right?
Mm-hmm.
You repair a hernia, the hernia can return, right?
Absolutely.
If you keep doing the specific things that cause the hernia to occur.
And do you think they would ask anything on their urinary retention specifically on this case?
Probably not, because she had the cystocele.
Okay.
I mean, I'm not a urogynecologist who's
Right.
testing your GYNs, urogynecology and oncology. Yeah, I mean, I know the practice bulletin recommends a post-void residual
Mm-hmm.
beyond a history and physical to evaluate pelvic organ prolapse.
Right. Okay.
I guess another issue or another question is, did she have any uterine prolapse?
Okay. No, she
If
didn't.
she had anterior and posterior defects, why didn't she have an apical defect?
Mm-hmm.
Because obviously there's something wrong with her tissue.
Right.
I mean, maybe she has more collagen component or what have you. I mean, she's young, 25, to have
Yes,
had this, for sure. But I would suspect she'll have a recurrence because of her
okay,
age.
right.
And at that point, you definitely would have to send her to urogynecology because she's had this surgery before. So there'll be adhesions and that type of thing. It won't be
Absolutely.
a straightforward anterior or posterior repair.
Right.
So questions on that? Very good.
Thank you.
But you were chickening out. You were chickening out. You were saying all the right terms, and we were saying them in a little different order.
I think I knew the terms. I didn't know the order of the terms. So
Mhm.
this was helpful. This was definitely a case I was worried about.
No worries. Very good. Good job. If anybody has any questions, just please put them in the question box. And I did look up. Oh, somebody has a question. It was 0.25, so I was incorrect. My apologies. Okay. Thank you. Ruby's saying 0.25 milligrams terbutaline. Very good. Thank you, Ruby. But it is sub-Q. I've done some case list reviews that people had IM. It's not IM. It is sub-Q. So I have Jacqueline saying that they allow you to have clean paper, and ABOG has an official video. You can use the blank paper during the exam to write stuff down. They will likely make us destroy notes at the end. Cannot come with case list with notes, only a clean case list. Yeah, we talked about that yesterday. Fresh, printed, de-identified, no handwritten notes on the case list before or during the exam. Would they ask about different pessaries, ring, Ageron, or Gellhorn? Yes, they can. I don't know how, you know, in a 25-year-old, usually I'm not surprised the patient wanted surgery because they usually want surgery when they're younger. But I would think more for an older patient. I think what I like to ask is how you do your pessary fitting, you know, and what particular pessaries you like to use and so on and so forth. Does that help you there, Jacqueline? But yeah, I mean, definitely, I'm thinking more for the office case. An office case, they'd ask more about the pessaries. In the GYN, I would think more surgical, is what I'm thinking. Because, you know, urogynecologists and GYN oncologists, they do surgery, right? So that's why I asked her about the anterior repair. Okay. So I'm looking for another person. I have Janelle. I'm coming to your direction. Says you're self-muted. You there, Janelle? Says you're self-muted.
Oh,
You there?
here I am. Yep. Hello.
Awesome. You're there?
Yeah,
Awesome. Are you a generalist or subspecialist?
I'm an MFM fellow
Of
too.
course. Of course. What are you looking for? What would you like to be tested?
Office or GYN? I guess I can do office if they just did.
Okay. Let's go find your list. Any specific case that's bothering you? Worrying you?
No. Yeah, any of them are fine.
Okay, I'm just looking through. Okay.
Mm-hmm.
Page 13.
Okay.
Can you tell me a differential diagnosis for vulvar ulcer?
So vulvar ulcer, my differential would include herpetic lesion, would include syphilis, Haemophilus ducreyi, And then would include vulvar malignancy and neoplasia. I'll stop there.
Anything else?
No, not for now.
So what is the difference between primary HSV and non-primary HSV?
Yeah, so primary HSV is the first outbreak that the patient has ever had of HSV of any type. And then a non-primary episode is when it's the first outbreak of a different type of HSV, but they've had the other type before.
So this patient was pregnant. Let's say she was not pregnant, okay? How would you treat somebody who has an outbreak?
So for a primary episode of HSV, I typically treat with acyclovir, and it's 400 milligrams 3 times a day for a week.
And what is suppressive therapy? Not for pregnant patients.
Yeah, suppressive therapy,
I guess who qualifies for suppressive therapy? Again, let's not discuss pregnancy because you should know that.
yeah. So I believe if you've had 3 or more outbreaks in a year, you qualify for suppressive therapy.
Now, is there a time limit on your suppression?
I don't think so, but I'm not sure.
Is there any concern for resistance?
I'm not sure. I think resistance is very rare in these cases, but I'm not sure.
So I'm going to change the story a little bit. So let's say the patient has syphilis. Can you tell
Okay.
me the different stages of syphilis and its treatment?
Okay. So syphilis, the first stage is the primary chancre, the painless chancre. And then second stage of syphilis, is the maculopapular rash. So typically you think of like hands and feet maculopapular rash. And then tertiary syphilis is I'm not sure. I'd have to look that up.
What's latent syphilis?
Latent syphilis, I believe, is when you've had syphilis for over a year. These patients can be asymptomatic. Then syphilis can, the reason we worry about that and want to treat it is because syphilis can down the line cause neurologic complications and can reactivate.
So how do you treat the different stages?
Yeah, so the preferred treatment for syphilis is penicillin G. For if it's primary syphilis, they only need 1 dose of the penicillin, but if it's,
What's the dosing?
I don't remember.
Okay, continue.
If it's any other stage of syphilis, though, then they need 3 doses of the medication. So it's important to know what stage they're.
3 doses, how?
I don't recall exactly what the timing is. I think it's
So
monthly.
go ahead, I'm sorry.
I think it's monthly, but I'm not sure.
So let me ask you this. Have you ever treated a patient who is pregnant and has syphilis?
I have. It's been a long time, but I have.
Okay. So if the patient was not pregnant,
Mhm.
any other options that you could treat with?
Yeah, I think doxycycline is also an option for syphilis.
Anything else?
That's all I'm aware of.
So of course the patient's pregnant
Mhm.
and she's allergic to penicillin.
Yeah.
What would you do in that situation?
So in those situations, we do penicillin desensitization, and it's mostly because penicillin is the best treatment with the least resistance to syphilis, and we want to make sure that these patients are adequately treated. So,
So is there any so syphilis, so the penicillin, there is resistance to penicillin with syphilis? Why is it so important to treat a pregnant woman with penicillin?
because there can be resistance to doxycycline, the alternative regimen.
So you would give doxycycline in a patient who is pregnant?
No, I would not. And doxycycline is generally contraindicated in pregnancy, but they can't even receive that medication because because it's not as effective, and we want to make sure that they're fully treated. So
What if I told you another option is erythromycin
oh
treatment?
yeah, I think it's still because penicillin G is the most efficacious treatment for syphilis.
But why in pregnancy?
Why in pregnancy? I guess I don't know. That would have been my answer, that there's likely more resistance with erythromycin. But I'm not sure.
Why do we give patients GBS prophylaxis?
Because we want to reduce the risk of neonatal GBS disease.
And how does that work?
The GBS prophylaxis is going to reduce the amount of just GBS flora in the genital tract, and reduce the likelihood that the neonate would acquire GBS as when it's born.
There's no another reason?
And it's also treatment for GBS, so it's also prophylaxis for the infant. It crosses the placenta and
You just said it crosses the placenta. So why do you use penicillin for syphilis?
oh, it crosses the placenta. Okay.
Yep.
Okay.
Makes sense?
Yeah.
Because the erythromycin, the specific erythromycin that you can use if you're not pregnant, you can't cross the placenta.
Okay. Sounds good.
Makes sense?
Yeah. Yeah.
So let me ask you this, when you desensitize somebody, how do you desensitize them?
So I don't know the exact scheduling, but essentially you give them very small doses of the penicillin G over a prolonged period of time. I know when I did it in residency, we would admit these people to labor and delivery to do that. So if they had any signs of an allergic
So
reaction.
how would they desensitize? Would be IV, IM?
It was IV, I'm pretty sure.
They did it IV? You sure it wasn't PO?
I thought it was, but I guess I'm not sure.
'Cause I've never seen anybody desensitized. But from my understanding, the easiest way to do it is by drinking little aliquots
Okay.
of different level, titrations of penicillin, and you have to do it in the ICU. And it's very costly. Okay, here's the question. Once somebody gets desensitized, are they desensitized for life?
I'm gonna say no, but
So if she needs 3 injections, you'd have to desensitize her all over again.
yeah.
So how do you avoid that? You give her a small dose of penicillin to take on a daily basis so she can take their weekly injections, but we're going to go over that. I asked that from infectious disease specialist because I personally have never seen anybody be desensitized. This is what they explained to me.
Okay.
So questions?
No, I mean, that was not yet. That was good.
Well,
needed that.
syphilis is getting a resurgence. So,
Yeah.
you know, everybody says it comes back to haunt you on this exam. So vulvar ulcer differential, you have your HSV, a chancre, which is primary syphilis, the painless ulcer, and that's where the spirochete enters the body. Lymphogranuloma venereum, which is due to chlamydia L1, L2, L3. Granuloma inguinale, that's Klebsiella granulatus, or it used to be Campylobacter when I was a resident. Chancroid, Haemophilus ducrei, VIN, vulvar cancer. Okay, so
Okay.
syphilis. Primary syphilis is the chancre. Roughly 4 to 8 weeks after that, you could get secondary syphilis, and that's the rash in the torso and the palms and soles of the hands and feet. It could lead to condyloma lata. It could give you like flu-like symptoms.
Okay.
Tertiary syphilis is due to gummas. That's usually over a year after exposure, a year to 10 years of exposure, and vascular aneurysms. So it causes cardiovascular issues. Neurosyphilis can occur at any point of the infectious process of syphilis. Usually, it could be more associated, I'm not going to say tertiary syphilis, but the longer you have it, because neurosyphilis is a different treatment. The tabes dorsalis, you know, the brain can become Swiss cheese, unfortunately, because of the spirochetes. Latent syphilis means positive testing with no symptomatology. And that's broken up into early latent and late latent. Early latent being less than a year, late latent being more than a year. Okay? Making sense?
Yeah, makes sense.
Primary, secondary, and early latent syphilis, so anything less than a year, gets treated with benzathine, penicillin G, 2.4 million units, IM times 1 injection. Late latent or tertiary syphilis is treated with 3 weekly injections. Neurosyphilis is treated with aqueous IV penicillin, completely different.
Okay.
Also, if you're not sure when the patient was exposed, you call her late latent. And you give her the 3 injections.
Okay.
Okay? That makes sense?
Yeah, it does. No, thank you.
Any questions about the desensitization? So if she's pregnant, she has to be desensitized if she's allergic, so it can cross the placenta.
Okay. I'm trying to think if I have any questions. No, that was really helpful. Thank you.
All right, no worries, very good. All right, let's see if anybody has any questions. Oh, I got some questions here. Hold on, let's take a look here. So somebody wants, please review the Baden-Walker stage versus POPQ. They're literally the same, Elizabeth. Let me see if I can get the specifics here. Let me see. So with the POPQ, stage 0 is no prolapse, so points AA, AP, BA, BP are all at -3. Stage 1, most distal portion of prolapse is greater than 1 centimeter proximal to the hymen. Quantitation value of less than -1 centimeter. Stage 2, most distal portion of prolapse is between less than 1 centimeter proximal to the hymen and greater than 1 centimeter distal to the hymen. Quantitation of greater than -1 centimeter to +1 centimeter. Stage 3, most distal portion of prolapse is between greater than 1 centimeter distal to the hymen, but no further than 2 centimeters less than the total vaginal length. Maximum prolapse is more than 1 centimeter beyond the hymen, but 2 centimeters less than the maximum protrusion. Stage 4, it's an eversion of the total vaginal length, or TVL -2. So hopefully that answers that question for you, Elizabeth, okay? So somebody wrote here, if we don't use pessaries and refer all those to Urogyne, what is the best information we would need to know regarding this? Well, Christine, like I personally like using a ring pessary with support. I think that's the easiest one for the patient to remove on themselves. And you can educate them on placing it, and you just have to kind of gauge the size. And you have the fitter, you place it in the patient, and you'll have her walk around, void, make sure it doesn't expel or it's not uncomfortable to her. And it's more like how she feels with it in place and is able to void. If she Valsalvas to void and it pops out, it's too small of a size, so you have to go to a bigger size. But that's just a quick overview. I know there's very specific, pessaries that help more with like, stress incontinence and stuff like that, but that's beyond the scope of what I know. But I think the simplest just to keep things in place is the ring pessary with support. So I don't know if that answers your question, Christine. So I would know something basic like that, So I have an odd question here from Rafif. You have an IUFD at 22 weeks with a previa. Can you do a D&E for her or a C-section? Ooh, that would be more of an MFM question, and we have a lot of MFMs on the call today. I think you would do a D&E on her if you're experienced doing a D&E because you have the previa, but the fetal demise, you hopefully not much blood will go to the baby at that point or the placenta, so she hopefully won't bleed. Janelle, I'm going to come to you here real quick. Are you there, Janelle?
Yeah, you can definitely do a D&E. That's all I was saying.
Yeah.
And
Now, would you be able to do like a cytotech induction or no? Because I know once the baby's is passed, you're not going to have that much blood flow.
yeah, I mean, we
If it was a
typically,
termination, it needs to be a D&E, correct?
yeah,
Because she'll bleed like stink.
yeah. I think for an induction too, we would probably counsel them towards a D&E because we could mitigate bleeding more.
Okay.
Not sure if induction's contraindicated though.
Okay. So hopefully that answers Rafif's question. Thank you so much, Janelle. So I have Jennifer having she had a patient desensitized because I've never seen anybody go through this process. So see what I had a patient desensitized, and so long as she got her injection weekly ×3 and didn't miss it one day, she was able to go for the next injection at my hospital. Okay, but if she was even one day late for the next treatment, she had to go back for desensitization. So I guess it's good for the week, because I've heard from ID specialists that they give them a low dose to maintain that sensitization. So cool. All right. And she will forward the treatment ID specialist and pharmacy made for our hospital. That'd be cool. I'm sure this isn't the only way to manage, but that's what they do here. That'd be cool. Jennifer, if you can forward that. Oh, yes. My apologies, Rafif. Treatment for suppressive treatment. I completely forgot about that. My apologies. So Janelle was correct with the primary versus non-primary. So candidates for suppressive therapy, according to UpToDate, those with severe or frequent greater than 6 per year. Or you want to reduce the risk of transmission to the uninfected partner. Okay, so there is really no documented time limit for suppressive treatment. However, no studies have been done beyond a year. However, there have been individuals that have been on suppressive treatment for over 7 years. And it's very low risk of resistance if the patient's immunocompetent. This is according to UpToDate. Okay, so hopefully that answers your question there, Rafif. I have a question about STRH. I thought it was above 3 to call it abnormal. I'm not an MFM. I can go to Janelle again, but to my understanding, it's greater than 95th percentile for the estimated gestational age because it changes with your gestational age. Janelle, I'm trying to unmute you there. I'm going to pepper you as our MFM. Are you there?
Yeah, It's above 95th percentile.
95th. So when they say 3, what is the 3? I mean, it depends on your gestational age, right?
Sorry, are we talking about SD ratios? I missed the first part of it.
Yes.
Okay. When they say 3, what do you?
This is
Like
what they
the
were. I have a question about SD ratio. I thought it was above 3 to call it abnormal, is what they wrote.
No, yeah, it depends on the gestational age. So 95th percentile. We'll
Okay, so
plug
gestational age. Good.
biology. Yeah.
Okay, cool. So hopefully that answers your question, Maria. Thank you, Janelle. I have Jacqueline here. She has a very nice link for pessary. I'm going to send it to everybody. Hopefully that goes to everybody here. Give me a second. Hopefully everybody's getting that. Thank you, Jacqueline. And it has a video on sizing. Jennifer, thank you. That is correct. That is my email. All right, cool. Anybody else want to be part of the hot seat? I think we have all our questions all answered. Laura, I'm going in your direction. Says you're self-muted. You there, Laura?
Yeah, hi.
How we doing?
I'm good. How are you?
Remind me, you're a generalist, correct?
Yeah.
Okay. Are you interested in a specific case?
No.
What are you looking for? Any specific section?
No, whatever.
Okay, you seem so excited. Case number 4.
Okay.
So what's the mechanism of action of betamethasone?
Betamethasone, the mechanism of action. I believe that it helps with oh my God, the development of oh my gosh, the pneumocytes. That's all I remember.
It helps the development of pneumocytes.
In the fetal lung.
To do what?
To help with respiratory efforts at birth. So decrease in increases their surfactant production.
And what's the earliest you would see the betamethasone cross the placenta?
The earliest, like gestational age?
Time-wise. So you give the betamethasone. When would you see it cross the placenta? In what time frame?
I believe, I'm not sure exactly. If I had to guess, I would say 12 hours.
And you said antibiotics. What antibiotics did you give this patient and why? What was the purpose of the antibiotics?
case for antibiotics. This patient had preterm premature rupture of membranes at 32 weeks, so she received latency antibiotics. She initially was not in preterm labor, so she
So what latency antibiotics did you give her?
she received IV azithromycin, and then she received ampicillin as well. And
So
she ended up
why did she receive the azithromycin?
to treat mycoplasma.
How about the ampicillin?
Gram positive and I think some gram negative coverage, but mostly gram positive.
So what was the dosing?
She got 2 grams Q6, and I believe 1 gram of the azithro. And she ended up going into preterm labor.
So let me interject here. So you give her 2 grams IV every 6, you said? Well, how long?
For 48 hours.
And then you're done?
And then she would transition, had she made it that long, she would have transitioned then to PO.
Will be the dosing there?
She would get amoxicillin for 5 days.
You know the dosing there?
I would have to look it up.
So let's say the patient was penicillin allergic. What antibiotics would you start?
She could get Gent and Clinda.
You know the dosing?
She would get Clinda 900 Q8, and she would get Gent 5 mg per kg Q24 hours.
For how long, both medications?
Those would be for 48 hours as well. And then this is if, I guess, if she couldn't have like a cephalosporin, and then she would get she would get oral clindamycin for 5 days. I'm not sure of the dose of the oral offhand.
Okay. So you want to keep telling me about the story about her going to preterm labor? So tell me
Sure.
what happened.
So she initially just came in with PPROM, was found to be breech, and was receiving latency antibiotics, got a dose of steroids, and then pretty rapidly started to have contractions and started to have dilation. So when she first came in, we did a speculum exam to diagnose her PPROM and saw that her cervix appeared closed. However, all of a sudden she started to become very, very uncomfortable, was having what appeared to be bloody show, and on exam was about 5 centimeters dilated. And so she had
So was there any concern for choreo?
She had, no, not at that time. She didn't have any fever. She had no abnormal vital signs. The baby's tracing was normal. No fetal tachycardia. And
So let's say, unfortunately, she wasn't 5 centimeters dilated. She was completely dilated, and she was delivering as a breech. Discuss for me how you deliver a breech.
so if she was delivering as a breech, I would first bring her back to the operating room to do this if I had time, ideally. And I would have her push until the majority of about to the line of the nipple, the line of the nipples on the baby, and then I would try to feel for the feet, depending on the position of the baby, and just sweep the feet out from the vagina. At this point, they would probably be pretty close to coming out.
So what is that
And-
maneuver that helps assist the delivery of the legs?
Pinard, the Pinard maneuver.
Okay. Continue.
Then I would usually take a blue towel from the OR, wrap it around the baby's abdomen and waist. And at this point, I would have her continue pushing until I was able to deliver the arms. And the way I would do that is I would hold the baby in a position parallel to the floor with the shoulders anterior and posterior. And I would start by sweeping the anterior shoulder, the anterior arm down across baby's chest and outwards from the vagina. Then I would rotate the baby in the opposite orientation and do the same.
What is that called?
I'm not sure what that is called.
Okay, continue.
And then I would, so then at this point, both of the legs, both of the arms and the legs would be out. So at this point, I would have an assistant hold at the towel, hold the baby's body up above the maternal abdomen, and I would have her continue pushing. I would ideally palpate, make sure that the cervix is free from the baby's head, and I would guide the flexion of the head, and ideally deliver it. I could do a Marisol Smelly Vite, where I put pressure on the zygomatic arch to flex the head, and then as she pushed, ideally the head would deliver.
So of course the head doesn't deliver. So
Mhm.
what would you do?
I would again make sure that there was no cervix causing head entrapment, which in this scenario would be possible at 32 weeks. If there wasn't, I could continue trying to flex the head.
So what would you do to help you do that?
I could put pressure on the roof of the mouth as well when I did it with one finger in the mouth to help aid inflection as well, to see if that would work.
What else
too.
can you do to aid inflection?
I could give suprapubic, or have an assistant give suprapubic pressure.
Anything else you can do?
I could I could do a medial-lateral episiotomy as well, or just to help if there was a vaginal tissue obstruction rather than something from the cervix. I could do that as well for more space.
Okay, so you do that, still the head's trapped. What would you do?
I could, if there was, if there was no cervix in the way and the head was just trapped, I could ask if there was someone else there who was familiar using the pipers, who could help me.
Unfortunately, nobody's available. It's just you.
Okay. So I have never used pipers myself. However, it is, I'm under the impression that the way that they were used, if I had to use them, is I would have somebody hold the baby up, their body above me, and I would be in a kneeling position, and I would place my left-sided blade first, being careful not to injure the ear, the head, but I would place it, I think, over the ear on the side of the face, and then I would place the right blade as well And then I would lock the locking mechanism, and I would try to use them to flex the head that way and deliver the baby.
So what do you do with the pipers once they're placed?
I think I would pull, I'm not entirely sure at the angle that I would be pulling, but I mean, if I was trying to flex the head, I suppose it would be upward, but I don't know for sure.
So let's say you get a head entrapment at the cervix. What would you do?
I would consider cutting a Druzens.
How do you do that?
So this would be 3 incisions on the cervix, one at 12 o'clock, one at, I guess, I can't remember if it's an upside down peace sign or peace sign, but I think I would cut it at,
It's an upside down peace sign.
so 6, and then 2 o'clock and 10 o'clock
Why is it an upside down peace sign?
to avoid the cervical branch of the uterine artery
Anything else?
and to avoid the bladder. Well,
Okay,
actually,
so that doesn't work. No, you're right. You avoid the bladder.
yeah, okay.
Okay, so that doesn't work. What would you do?
I would, so that doesn't work for the, I guess at that point, if the head is entrapped, I can't use the pipers. I've got a piece on it. I could potentially make like a suprapubic incision, almost like a Fannin steel, and I could try to get closer to the head from above than just with suprapubic pressure and try to,
So you would do an abdominal rescue.
yeah, essentially.
You would do an ELAP.
A what?
An ELAP, you do an exploratory laparotomy and
Yeah, I
try
mean,
to
I would
deliver the baby from.
I would start by just trying to,
I'm sorry?
yeah, I would essentially make an incision and try to push directly on the head, either from, if I could do it after just getting, yeah, either above the uterus or actually cutting into the uterus and pushing directly.
Okay, let's stop there. What'd you think?
I feel like I should have known more of the antibiotic doses, but they blanked me in the moment.
Okay, mechanism of action, betamethasone accelerates the development of type 1 and type 2 pneumocytes, leading to structural and biochemical changes that improve both lung mechanics and gas exchange, induction of type 2 pneumocytes to increase the surfactant production. How quickly does it cross the placenta? Concentration in cord blood is approximately 20% of maternal levels 1 hour after administration. So pretty quick. Latency antibiotics, azithromycin 1 gram PO on admission, plus ampicillin 2 grams IV every 6 hours times 48 hours, followed by amoxicillin 875 milligrams PO times 12 hours, or 500 milligrams PO Q every 8 hours times 5 days. You can use erythromycin as well. The practice bulletin says erythromycin. This is what UpToDate says, and that's what I'm used to doing in my hospitals.
Yeah.
Azithromycin targets ureaplasma, mycoplasma, chlamydia. Ampicillin and amoxicillin specifically targets GBS and many aerobic gram-negative bacilli and some anaerobes. If you're penicillin allergic with anaphylaxis, azithromycin plus clindamycin 900 milligrams IV every 8 hours times 48 hours plus gentamicin 5 milligrams per kilogram every 24 hours times 2 doses, followed by clindamycin 300 milligrams every 8 hours for 5 doses. The Pannar delivers the baby's legs. The Loveset delivers the baby's arms. Okay. The Piper forceps, you want to go in a J fashion down to up towards the mom's abdomen. Okay.
Okay.
That's the rotation, for lack of a better word, that you do. The Dursens is the backwards Mercedes signs or peace sign, whatever you want to call it, because you want to hit the bladder. Okay. And you don't have to do all 3 incisions at the same time. You do one first, see if that helps.
Okay.
The other, okay. You could give, if that doesn't work, you could do give a uterine relaxant like nitroglycerin. That's 50 mg IV every minute for 5 doses.
Yeah.
Okay.
Okay.
Questions on that?
No, I think that was it.
Okay, very good.
Thank
Did we
you.
answer everything that we asked you? I think so.
I think so.
Okay, awesome. I'm gonna see if anybody has any questions. So Show P is saying, would it be reasonable to do an emergency cesarean in this patient since the baby was preterm? You can, but for the purpose of the exam, they're gonna be saying that the baby's butt's coming out. Right? So head entrapment is much increased because the head is bigger when they're preterm. So definitely you could do that, but of course on the exam they're going to say, no, you can't do that because the baby's coming out. If that makes any sense. Okay. So if people are okay, I got no problem doing one more. Hannah, I'm going in your direction. Says you're self-muted.
Can you hear me?
Yep, I can hear you. How you doing?
Good. How are you?
We're hanging in there. That's all we can do. Are you a subspecialist or a generalist?
I'm a generalist.
Okay, what are you interested in getting tested? Any specific case?
No, I'm up for anything.
Okay. The pressure. Figure get something good. You want want a specific section?
No, I don't think so. I can't see the cases
No,
though.
I don't have it. I don't have it yet. I haven't put it up yet for you.
Oh, okay,
I will.
perfect. I just
Yep,
wanted
yep,
to
yep.
make sure I didn't close the
Yep.
screen.
No,
Thanks.
You're good. I'm not showing it yet. Case number 14. How do you prevent fluid overload in your operative hysteroscopies?
So for operative hysteroscopy, using an electrolyte medium, I would not utilize more than a 2.5 liter deficit as my upper limit. However, I would be concerned about any rapid accumulation of a deficit, and I would start to be concerned at about 1 liter.
Anything else that you would do to prevent your fluid overload?
So for patients who would be at increased risk for fluid overload would be any patient with a cardiac condition. And so I would, for a patient that I was concerned may not handle fluid well, I would not use more than, I would stop after 750 mils of a deficit. So I would just be very careful as well about counseling and patient risk factors.
Anything else to prevent fluid overload?
So my understanding of the question is this would be preventative as opposed to at the time that you are concerned that you have exceeded your deficit. However,
Yes,
if you
things
did
that you,
exceed,
yeah, exactly.
okay. Things that I would do to prevent fluid overload from a purely preventative standpoint as well would be to utilize the suction feature of the hysteroscope so that I'm able to be acutely aware of my deficit so that I could carefully monitor that.
Anything else?
There have been times that the cervix is dilated beyond the width of the scope, and so excess fluid just like rush out and into the collection bag. So again, I would just make sure that I have a very good accounting of my fluid. But other than that, that's where I would start.
So what different types of fluids can you use during a hysteroscopy?
So you can use electrolyte-rich fluid, isotonic or electrolyte-poor fluid media.
So for your electrolyte rich, your max is what again?
Maximum would be 2.5 liters fluid deficit.
And what about electrolyte poor?
Electrolyte poor, I would be concerned at approximately 1 liter.
And can you tell me what type of media are electrolyte poor?
Sorbitol is an example of an electrolyte poor, as well as glycine.
So what is glycine broken down to?
I would have to get back to you on that.
And what about sorbitol?
I would have to get back to you on that as well for specifics. However, my understanding is that it would be some amount of free water and potentially like a carbohydrate component.
So if you have fluid overload with a hyperosmolar media, how would the patient present?
For a hyperosmolar media, the patient would present initially with vital sign changes, could present with increased respiratory rate, tachycardia. If the patient is already extubated and awakened, could present potentially with mental status changes as well.
And if somebody has overload with isomolar fluid, how would they present?
My understanding is that they would present with similar symptoms of volume overload.
Can you discuss the submucosal myoma classification system?
Yes, I can. So starting with type, the range starts with 0. Oh, is this just specifically for submucosal?
Yes.
Okay. Okay, so in general, leiomyomas are classified from 0 to 8, and then specifically, so for a completely submucosal, the submucosal would be anywhere from, it would not be type 0 because that would be completely intracavitary, but so it could be type 1 or type 2, where more than 50% is in the cavity, or less than 50% is in the cavity, and then possibly type 3, where like a very small portion, but the majority of the leiomyoma would be in the myometrium.
So which type has a greater absorption of fluid during operative hysteroscopy?
So my understanding is that if you have a myoma that is completely intracavitary, you would have a lower risk for absorption of fluid because you are not, you're able to remove the myoma completely, and you would not be abutting the instrument against the myometrium, and also would be able to potentially resect the myoma more quickly as well.
I'm sorry, you broke up. Say again, which type?
So my understanding of your question is which type of leiomyoma would have the greatest risk for fluid overload, or which type of
Greatest absorption of fluid during the operative
greatest
hysteroscopy.
absorption? So my understanding would be that a myoma that would be partially intramural would have a greater risk for fluid absorption.
So which type, 0, 1, or 2?
Probably, most likely 2.
Okay, so between a uterine perforation and a type 2 myoma, which one had the greater fluid absorption?
A uterine perforation would be more concerning for fluid absorption.
Why?
Because with the uterine perforation, you would have fluid escaping the uterus and therefore systemic absorption.
So let's say you have your patient that she appears to have gotten fluid overloaded during your operative hysteroscopy. How would you manage this patient in the recovery room?
So initially, I would notify the charge nurse as well as the anesthesia, that I was concerned about fluid overload in this patient, and I would ensure that she has active vital sign monitoring, and I would administer Lasix to the patient to assist with diuresis.
Would you do any lab work?
Yes, I would. I would obtain electrolytes as well. Yeah, I'd obtain a CMP for electrolytes.
And what are you looking for the electrolytes?
I would be looking for sodium as well as potassium and calcium.
So what's the biggest issue when it comes to fluid overload with a hyperosmolar fluid?
The biggest issue would be pulmonary. So pulmonary edema or flash pulmonary edema, as well as like an acute cardiac overload as well.
Anything else?
I believe that you would, in correcting hyponatremia, you would be concerned about how rapidly you correct that because of the risk of central pontine myelinolysis as well.
Okay, let's stop there. What'd you think?
Yeah, this was really helpful and very tough. So thank you for asking such specific questions.
Sorry. Okay, prevent fluid overload during an operative hysteroscopy. You want to use, because when I was a resident, we did hyperosmolar. There was no isomolar fluid. So you want to use isomolar fluid. You monitor your fluid deficit. You maintain the lowest intrauterine fluid pressure. You want to limit your surgery to less than an hour. As well, if you put vasopressin in a paracervical type of block, that can decrease absorption as well. You're correct with isomolar fluid. It's 2,500 cc's is your really maximum. You shouldn't end at that point. You should be stopping way before that. Hyperosmolar fluid is at 1,000 cc's. You were correct. Type 0 is completely within the endometrial cavity. Type 1 extends less than 50% into the myometrium, and type 2 extends to more than 50% into the myometrium. So type 2, because you're cutting more into the myometrium, has a greater risk of absorption. What has a greater risk of absorption? Type 2 resection or a uterine perforation, it would be the type 2, because the uterine perforation, even though fluid is going into the cavity or the peritoneum, it takes a longer time to absorb compared to cutting straight into the vascularity. Make sense?
Okay, yes, that makes sense. Thank you.
So electrolyte poor solution or media, you have your glycine, sorbitol, mannitol. Okay, glycine is metabolized to serine and ammonia. Sorbitol is metabolized to glucose and fructose in the liver and then to carbon dioxide and water. Mannitol does not enter cells and is not metabolized. It's excreted entirely in the urine. Okay, so when you have your isomolar fluid, the fluid overload will lead to pulmonary edema, congestive heart failure. Okay? With electrolyte poor or the hyperosmolar fluid, it's mainly the hyponatremia, hyperammonia, decreased serum osmolarity, potentially leading to seizures, cerebral edema, and death. Okay? And you're correct. The hyponatremia, if it's corrected too quickly, could lead to that central pontine myelitis or whatever it's called. Like you literally have herniation or something of the brain. So when you talk about concerns for, you know, the fluid overload with the hyponatremia and all that, it's with the hyperosmolar fluid. You can still have issues, don't get me wrong, with the isoosmolar fluid, you know, with the normal saline or the LR, with the pulmonary edema and congestion. You can kill somebody doing that, right? And of course, if you give them a lot of fluid, I guess with time you are going to get hyponatremia, but it's going to happen much quickly with the other type of media. In a nutshell, I'm not an expert. Okay.
Okay.
Other questions?
Yeah, I think that covers it. Thank you so much for reviewing it.
No, I think you did great. I mean, it's not an easy topic, but we all have hysteroscopies on our list, right?
Yes.
So that could be some questions they can ask.
Oh,
Okay.
actually, I do have a question.
Yeah.
So,
Hopefully I know the answer.
okay, so I think you will. Just the categories of fluid. So isomolar is normal saline and lactating
LR.
ringers.
Mhm.
And then, so
Mhm.
electrolyte poor is also hypoosmolar. Those are the same.
Yes, to my
Yeah.
understanding, it's one and the same. Yeah.
Okay,
In
and
the
is there,
categories.
okay. So there are 2 categories in total, but like kind of will have multiple names for each category.
Right.
So
And nowadays it's very rare to have the hyperosmolar for that particular reason, because you could get some significant fluid over, because I mean, you go into fluid overload a liter in versus 2.5 liters. Now, that being said,
that
if
makes
it's an
sense.
elderly patient who has issues already with their heart, you should, you know, kind of end much sooner than, you know, 2 liters, for example, if you were doing isomolar fluid. Making sense?
Yes, definitely.
Yeah. I mean, I'd be very cautious. I mean, young person, they have more of a reserve. Older person, not. And especially if you're using the hyperosmolar fluid.
Yes, that makes sense. Thank you so much.
Okay. But you know, on this test, they're gonna throw like curveballs at you, you know. That's what they do.
Well,
Other
I
questions?
appreciate all the curveballs. I appreciate all the curveballs in preparation. So thank you.
Very good. Good job.
Thank you.
So I have another question here. It says, can you use cephalosporin for mild penicillin allergy? I would suspect yes. Like you do so for your GBS. Is that what you're referencing to, Maria? I'm assuming that's what you're referencing to. Okay, does anybody have any questions? Okay, I have another question here from Angie. When do you use the 3% saline for replacement sodium less than 120 with symptoms? Yeah, at that point, if that's going on, I'm definitely going to be calling my internist for assistance or my specialist. Rapid correction of hyponatremia and hypoosmolarity is probably safe following hysteroscopy because of the extremely short duration of hyponatremia. This is from UpToDate. There has not been time for the cerebral adaptation that put patients with chronic hyponatremia at risk for osmotic demyelination or the central pontine myelolitis. Although demyelination is often more diffuse and does not necessarily involve the pons if the serum sodium is raised too quickly. Nevertheless, ACOG guidelines concluded that the serum sodium should not be raised by more than 12 milliequivalents per liter in the first 24 hours. The rate of correction should be slower, 8 to 10 milliequivalents per liter, maximum increase in the first 24 hours in patients who present with hyponatremia more than 48 hours after the procedure. By contrast, optimal therapy has not been defined in symptomatic patients who have severe hyponatremia, but a normal or near normal serum osmolarity, greater than 270 millimoles per kilogram. Hypertonic saline should probably not be used in such patients, and hemodialysis may be a safer approach for those patients. Okay? So hypertonic saline is indicated in symptomatic patients with marked hyponatremia who have a substantially reduced serum osmolality or cerebral edema. In addition to reducing cerebral edema, hypertonic saline replaces the potentially substantial urinary sodium losses that result from the osmotic diuresis caused by the distending media. When hypertonic saline is given, the patient is initially given 100 cc's of 3% saline as a bolus, which provides 51 milliequivalents of sodium and should acutely raise the serum sodium concentration by 2 to 3 milliequivalents per liter. If the neurologic symptoms do not improve, a 100 cc bolus of 3% saline can be given 1 or 2 more times at 10-minute intervals. That's according to UpToDate. Hopefully that answers your question, Angie. So Maria's saying for latency antibiotics. Oh, you got me there. Do we have any MFMs on the call? Let me see, is Janelle there? Or maybe Priyanka? Let me see, hold on. Janelle, I'm coming in your direction. I saw your name first.
Yeah, what was the question again?
So for latency antibiotics, can we use a cephalosporin? And if so, dosing?
There is an alternative regimen.
Okay,
Let me look it up real quick.
cool, appreciate it.
I'll type it in the box.
All right, perfect, thank you. So we're looking into that, Maria, okay? Any other questions? Anzi, did that answer your questions? Because I mean, realistically, you can give the theory on the exam on how to correct, but I think realistically, I would getting my internist or my specialist, because that, you know, we could really kill the patient if we're doing something wrong. Okay. So I have Ruby, she wrote down low risk for anaphylaxis if the patient's history suggests a low risk. Algorithm 1, we suggest penicillin allergy, immediate reactions, azithromycin 1 gram orally upon admission, plus Ancef 1 gram intravenously every 8 hours for 48 hours, followed by cephalexin 500 milligrams orally 4 times a day for 5 days. The cephalosporins provide coverage for both GBS and E. coli, the 2 major causes of neonatal infection. So Janelle said depends on low risk or high risk, and it looks like Ruby answered that question. So Angie is asking, I just wanted to see if they would ask something like this. They could, Angie. I suspect if you're getting to those type of questions, you've really done really well with all the questions preceding what they asked in regards to the hysteroscopy. Does that make sense? Okay. And Janelle's writing low risk azithro and Ancef and cephalexin to follow, just like Ruby wrote. So perfect. High risk, you do the azithromycin plus Clinda and Gent, kind of like what we discussed. Okay, on the case that we presented or put the person on the hot seat for. Other questions before I let you guys go? I know we went over a little bit, but you know, we got an extra case in and it was hysteroscopy fluid overload. So I think that's a good topic. So other questions? I don't see anybody putting any other questions. I'm gonna see if I can lower everybody's hands. Sometimes that's not as easy. Does anybody have something they need to say or ask a specific question? I think if people that still have their hands up are ones that had them up from before. Before I let everybody go, everybody's questions have been answered. Any other questions about anything? Hopefully you found this helpful, maybe not. Try to make it interesting when we're talking about specific cases. Try to make it more like a structured, use that case and springboard on topics so everybody on the call can learn something. So hopefully you find that beneficial. That's what we try to do here with the webinar, so everybody can learn something. So any other questions before I let everybody go? All righty, well, I really appreciate everybody. Thank you so much. Everybody that participated, I think, did a very good job. Kendra, Priyanka, Hadi, Janelle, Laurel, and Hannah, thank you so much for your participation. We're trying to get as many people on the hot seat as possible. Anything else before I let everybody go? All right, if anybody has any suggestions, please put it in the box because we're always trying to improve. I'll stay up on a couple of more minutes so you can have time to type things in and I can respond privately. But I appreciate everybody's time and attention, and I wish everybody a good rest of the night and a good rest of the week. Good night.